Talk about that for a second. Yeah, go ahead.
With that, though, and to Jim's point and your point, it's better indication of measurement of this quality. I mean, that's when you look at the technologies that are out, and the most recent technology coming down the pike deals with resurfacing. Intuitively, resurfacing makes sense if you're grabbing a patient early in life that he's giving it, knowing that you're going to have 20 or 22 or 24 years worth of expected. So there's going to be a revision involved, and that's the whole benefit of this. The trouble is there's been no measurement to the quality that has been done, and if there has been some measurement that's done, it has changed so fast from the technology moving on to the next technology, okay, that it then becomes meaningless. Okay. So I think measurement is a key element in this.
Let me just touch this out, though. Ford Motor Company just had a change at the top because they're not selling cars the way they used to. General Motors whoever thought that General Motors would be in the desperate straits that they seem to be in? And are we saying that profit for the device manufacturers is a dirty word? I mean, if the hospitals can't make the payroll or if they can't make a profit the way things are now, why should we punish those manufacturers who are doing a successful job? Why should they be the fall guy?
Well, I don't think they should be. I think profits in the American system are very good, and I think that goes for medical device manufacturers. I don't think anybody has a problem with that. I think there needs to be balance in the system. I think now you've got healthcare providers, doctors, hospitals, who are not having very good profit margins. So profits aren't the problem. I think, again, it's better reimbursement that provides appropriate pay for what the doctors are performing as well as what the hospitals are providing. But I don't think it's a medical device profit problem.
I think most physicians traditionally, when we were in training, we were never taught about what the prosthesis may cost, what the hospitals run, how they are reimbursed. We never knew any of this. All we know is what's best for our patients. Mm-hmm. And to be honest, I never have asked, well, how much does this product cost? Am I going to be okay to use this product? Guess what happens today? I've been in practice now a little over 15 years now, and now today, before I use a product, I have to think, are they going to let me use this product? In fact, I dictate where I do the surgery based on the product I'm using. For instance, if I'm replacing a finger joint, that procedure can be easily done as an outpatient surgery, yet I know if I use it at the outpatient surgery center, they won't let me do the procedure there because for some reason, a lot of insurance companies, including Medicare, will not reimburse for the implant for the finger. Now I have to do it at the hospital. If I do it at the hospital, Medicare reimburses for that implant. But yet, if I do it as an outpatient...
It's more expensive. It takes more of your time and it takes more of the hospital's time.
And not only that, the hospital charges 2 or 3 times for that procedure than what the surgery center would charge. Surgery center would only charge probably less than $1,000 to do that procedure. If you do it at the hospital bill, I believe the charges are around 2 or 3 times that of an outpatient surgery center. And then now you also have a prosthesis that costs a lot more than it would be if you do it at the outpatient surgery center.
Karen Barrow, does that make any sense to you?
No, it doesn't, but that's the reimbursement we're talking about. That's the situation we're in right now. I guess my question is, doctor, if you have the credible data and you know the hospital's margins are shrinking, would you sit down with your hospital right now and assist them in negotiating a competitive contract with your orthopedic vendor that you want to use?
I just had to do that. In fact, the hospital came to me, and I can't tell you why, but every hospital I've ever worked at have told us that their total joint replacement are money-losing venture. And I don't see how that's possible, by the way. And they show me the data. As they say, they lose about $5,000.
It's a little bit of a side trip, but tell me about that. Why do you think it's not possible?
Well, because if that's so, why are they so intent on recruiting us? They want my business. But at the same time, once we start bringing them business and start doing the cases, first thing out of their mouth is, by the way, total joints are only reimbursed $20,000 to the global fee to the hospital. And we're losing about $5,000 per case. But doctor, we want your business.
What do you think the reimbursement is for a total joint for a hospital for a 3-day stay?
global fee, I believe it was around $22,000, or at least one time. I don't know what it
Average
is
for
now.
Medicare right now is about $9,840 across the United States. So if your implant represents 40 to 50% of that, which it probably does, $5,000, $6,000 for a 3-day stay, that hospital is losing money under our current DRG system, under our current reimbursement system. So 67% of the patients that come in, which are Medicare patients for total joints, chances are your community hospital is losing money the minute that patient hits the mat at your operating room door.
So, Karen Matjucha, how do you make a profit out of that? If that being the situation, where's the hospital going to make its profit?
Well, in that particular situation, it's hard to see where the profit's going to come because you're looking at having to, you've got 3 components to reimbursement. You've got the labor, the facility room and board, and then you've got the actual implant itself. Unless you can cut the implant cost down to 0, you can't reduce your labor any further. Room and board is what it is. It's very hard to see that. So the answer is you have to either negotiate the price of the device down as far as you possibly can, but you've got to make it up on volume on more profitable cases. So when you say why are they recruiting you, it's to recruit you to balance out with the more profitable cases.
I don't see how that makes any sense. But all I can tell you is, again, I'm surprised the reimbursement for Medicare for a total joint 3 stays are only $9,000. There must be other things that they can, I know there are other things such as a rehab afterwards and that kind of things that they can make up for.
How come you think they're losing the money?
I don't understand it. I mean, I know that if I owned a business and somebody came to me and utilized my business and I actually lose money on that, I tell them to get them out of my business.
I think
But yet every hospital that I know is trying to recruit me and my partners because we have a high volume practice.
You're what they call a rainmaker.
well now you're looking at the lack of trust that's within there. Part of the problems that we haven't been able to come up with a collaborative effort amongst all the stakeholders has been is there a belief in the industry that the hospitals are losing money. I could tell you that over the last 15 years, I've been hearing that the hospitals are losing money in orthopedics. And back then, when the reimbursements were much higher and the implant cost was much lower, it was just unbelievable. Now, clearly, the margins are much narrower today than they were 10 years ago, 5 years ago, whatever it may be. But there's this lack of trust between the various parties on what they're hearing.
Karen, what's the most out-of-control device? If you could put your finger on one thing, what's the most out-of-control device?
I think we're hitting on one of the major ones. It's not so much that it's out of control, it's that the margins are so thin or in the negative right now, and that is total joints. And it's because of a reimbursement system that we're under. And it's also because, as physicians, you've taken a lot of the profitable procedures, your arthroscopies and your sports rehab, out of the hospitals for efficiency reasons. You may have other investments. You may simply get more patients done or seen in a day if you remove them from the hospital. So those profitable cases that used to make orthopedics very desirable are gone. So as far as out of line, we've got great new technology evolving, and I wouldn't want to see that stop. Being a soon-to-be baby boomer, I want to see some of these ICDs develop, and I want to see some of the things that are going on. I think probably we need to address with our physicians is the cost of the product, but also incorporate some quality monitors so that when my mother comes in at 72 and wants the Jack Nicklaus hip, that physician has something that's defensible and saying, here's the protocols either established by the Academy of Orthopedic Surgeons, established by the assistance of our GPO, but here's why, Mrs. Sachs, this particular product is appropriate for you, and this is why I would implant this in you. Right now, you're a private practice physician, you accept all the liability for your decisions. If that goes bad and my mom doesn't get the Jack Nicklaus hip, you're exposed.
So you say the hospital has an obligation to go to the doctors and say, look, this is as far as we can go.
Not to tell them, but to work with the physicians for protocols that are defendable, for quality protocols that give us all cost-effective quality care. You, me, and future generations to come.